First off, could you just give a bit of background about yourself and what you do?
All right, so my name is Dr. Zuri Murrell, and I'm born and raised in Los Angeles, California. I'm a colorectal surgeon, so I am a private practice, but I also work at Cedars-Sinai, and I'm chief of the cancer committee for the Cedars-Sinai Medical Center.
Great. So now could you just sort of explain what the current colon cancer rates are like and which areas are of particular concern?
Right, so colorectal cancer it's really interesting because it is the third most common cancer of men and women in this country. However, it is the number 2 cause of cancer-related deaths. And I'm here to tell you that it's almost totally preventable by 2 methods. 2 of those methods are, first of all, it's basically what we put in our bodies. Okay, and that's the hard thing. It's fighting obesity, what we put in our bodies, and we'll discuss that later. And then number 2, it's by getting appropriate screening with a colonoscopy. All colon cancer starts as these little growths called polyps. And these polyps are removed during a colonoscopy. I always tell my patients that a colonoscopy is not done to find cancer. It's the only test a man or woman can have that actually prevents cancer. And so what's interesting is that while we've seen a leveling off in terms of colorectal cancer rates and incidence, what we're seeing now is about a 12-fold increase in people who are younger than the age of 50 getting colon cancer. So it's important to note that most colon cancers are still in people over the age of 50. However, we've seen a huge growth in patients under the age of 50. Of note, African Americans have the highest rate of colorectal cancer in the world. However, if you look at Uganda, which I do a lot of medical mission work in Uganda, Nigeria, they have some of the lowest rates of colorectal cancer in the world. Now, there's very little separating an African American's genes from a Caucasian person, let alone an African American from an African. And the question you have to ask yourself is why is it like that? And what can we learn from that? And so when I always talk about colorectal cancer, I was saying there's things you can do things about, and there's things you can't do anything about. You can't do anything about your age. And once again, most colon cancers occur over the age of 50. You can't do anything about your race. And you can't do anything about your genes, okay? But what you can do on that aspect is you can learn from it. And you can talk to your family members, and we can learn about our family history because that is very empowering for patients, okay? Then there's modifiable factors. So when you look at why young people and why young African Americans, why is colorectal cancer more prevalent? So there's a lot of thought now with diet, okay, number 1. But it's not just diet in terms of how it relates to obesity. What's really neat is its diet as it relates to, and I apologize, I'm at the hospital today. But there's something called our gut microbiome. That's kind of been getting a lot of pub now, but microbiome is basically all of the bacteria that inhabit our gut, and the microbiota are the genes of all these bacteria. And so what we note is that if I told you, once again, African Americans, highest rate of colorectal cancer, Africans, specifically Nigeria and Uganda, lowest, okay? The main difference you see is diet. So in this country, we do know, and all over the world, that a pro-carcinogen, so that is something that if you eat enough of or you're around enough, it can lead to cancer, pro-carcinogen. And diets that are high in red meat and low in fiber are carcinogenic diets, okay? In this country, and especially African Americans and other groups here, eat a lot of red meat, which can be pro-carcinogen, and low fiber, okay? So we need high fiber. Now, when I always tell my patients high fiber, they're just like, first of all, they always think I'm talking about Metamucil, but that's just not it. There's delicious ways naturally to get fiber, such as blackberries, blueberries, raspberries. But the importance is, why does fiber help? So that starts with knowing what the colon is actually for. So when I ask people, what's the colon for? People always say, to make poop, but that is not the colon's job. The colon's job is to reabsorb water and for the body, okay? And the rectum's job is to hold stool until a socially appropriate time to defecate, all right? So fiber helps because fiber is not absorbed in the body, and fiber helps to hold water in your colon. So it's really important for all of the viewers and the people who read this to understand that when you first take food, you put it in your mouth and you start chewing, you masticate the food, you break up the food. The food goes down your esophagus to your stomach. The stomach, which has a lot of gastric acid there, actually breaks down the nutrients. Very little absorption happens in the stomach. All of these nutrients are then sent to the duodenum, jejunum, and ileum, which all make up the small intestine. That's where your absorption occurs. After all of the absorption occurs, whatever's left over, the waste and the water, goes to the colon. The colon's job is to reabsorb all that water as much as the body needs, and then to have enough left in the colon so you have an easier bowel movement, which is important for something called reducing the colonic transit time. The colonic transit time is from the time something gets to your colon to the time you expel the waste. Now, what I always say, and I do mean this pun, the quick and dirty way that anybody listening to this can check their colonic transit time, what's like a proxy for colonic transit time, is eating a plate of beets. If you eat a plate of beets and then you calculate how long it takes before you see red stool, where you think you're actually bleeding, that tells you you're basically, we look at it as a proxy for your colonic transit time, but that's really the transit time of your whole body. It should be between 24 and 30 hours. Okay, and so you're kind of you're operating at an optimal rate, colonic wise and gut wise, if you have it in this particular time. So that's what's important about that. Now, what we're learning is diets that are high in fiber, low in red meat, low in and have an effect on reducing the inflammatory bacteria in your gut. And we notice that diets that are high in fats and high in red meat and pro-carcinogens, actually you have more of that inflammatory bacteria, okay? And so what we notice is there's been studies actually where you have African Americans and they're put on a Western African diet. And you take the same group of the Western Africans and you put them on an American diet. And you do this even for 2 weeks. And then you go and you do colonoscopies and you biopsy the gut, and you see a decrease, even in 2 weeks, you see a big decrease in the pro-carcinogenic bacteria in the diet that went from low fiber to high fiber. And you see the reverse in the Africans who were given an American diet, they had more carcinogenic bacteria in their gut. Okay, so that's number one. Number two is in those countries, Uganda and Nigeria, there's not a lot of obesity. Here, 70% of millennials will be obese by the age of 35. That's huge. I mean, we have the highest rate of obesity in the world. And the problem with that is being obese in and of itself, the fats and adipose tissue, we're in a pro-inflammatory state. And so all of those things lead to cancer. In addition to if you have other habits, such as drinking alcohol or smoking cigarettes, all of these are they add on to the chance of you developing this particular cancer. So I want you to just hear how empowering that is, though. The fact that if you've been eating high fat, high red meat diets, low fiber diets your whole life, you literally change even for 2 weeks. For 2 weeks, you can see a change. Now, for these changes to actually reduce your chance of colorectal cancer, most likely you'd have to do something for years. But there really is a lot of truth in that, other than the fact of you just losing weight. We used to think that just being obese and losing weight would help you, but it's also because of that gut microbiome. And so it's incredibly important about what we put in our mouths. When you look at African Americans versus Caucasian Americans, we see that we have a twofold increase in colorectal cancer incidence below the age of 50. So 10% of African American cancers are in patients who are under the age of 50, whereas 5% for Caucasians. So in terms of all people, the biggest reason that we think we're seeing a increase in young people getting colorectal cancer is really because of the obesity epidemic. And that is something that is, it's hard to change that. The hardest things you could tell a patient to do without providing real significant guidance is stop smoking and lose weight. And people don't understand, I think, that the thinnest person at any age, after the age of 30, people who are thin actually are doing things to make themselves thin. my wife has the same build as you. And people look at my wife all the time. They're like, "Oh, you just must be thin." No, my wife's like, "No, I literally like eat oatmeal in the morning and blueberries, and I eat a dinner." Like she, you know what I mean? Like there, like no one, and I think that's a big misconception, excuse me, that a lot of people have is that, well, I'm just like this, or a person who's really thin and fit is just like that. After age 35, there is no just like that. Everybody's metabolism slows down, and it's by design. So I think the changing some of the cultural norms about what we put in our bodies and how we do that is something that's very important, but it's very difficult because when I was a kid, um, food, it was actually cheaper to cook at home than it was to go to fast food. But now you literally can get, a burger from McDonald's or something that's literally cheaper, quicker, and easier for you to feed your kids. If you work all day and you drive it home and then you have your kids in the back and they're screaming McDonald's, and it's hard to get home and then cook a healthy meal, especially when you live in certain areas where there's like a food desert, right? Right now, so my practice here in Beverly Hills, there's no fast food, there's no drive-throughs here in Beverly Hills. There's not a drive-through, there's not a McDonald's, there's no drive-throughs. Whereas where I grew up down the street, there's a million, there's a million drive-throughs and liquor stores and things of that nature. So part of it is that it's hard enough to make the right choice, but it's harder when it costs more money to make the right choice and you're not really versed in how to make it good, But on the flip side, though, you do know if we have different ways to attack that, and you show people different food options. One of my favorite things to do, especially for men, to get them to, especially for young men, to get them to do fiber, right? So when I say fiber, everybody thinks you have to scoop Metamucil in the water and drink it. So blackberries, blueberries, raspberries have about 4.2 to 7.2 grams of fiber per cup. Every morning, and my kids do this for me now, and I do it for them sometimes, is 2 cups of berries, almond milk, because it's lactose intolerant, and everybody can tolerate almond milk unless you're allergic to almonds, and then we find another substitute, ice, and a little protein powder. You blend that, you're walking out the door with 14 grams of fiber. We need 25 to 30 grams of fiber a day. And that's a delicious way to get fiber. So part of my outreach when I go to different churches, barbershops, things of that nature, is trying to find, not just to preach, so to speak, to patients, but work with them and try to find, try to show healthy alternatives. I think the biggest thing I tell people is you have to be your own healthcare advocate. What does that mean? That means that the doctor's appointment is prepared. So what I tell patients is the reason that I'm out of insurance is because obviously I like to talk, Ms. Slater. So I want to spend time with my doctors. Have so many constraints on them, especially if you work in certain health systems. If you work in a HMO health system, you have to see a certain number of patients every hour. So what I tell patients is that's an us problem. That's not a you problem. You have to know what you want to get out of your appointment, and you and your doctor are a team. Okay. The days are over where I dictate to you what to do. And I also tell patients that works both ways, meaning that I cannot love you more than you love yourself. So, we work on a treatment plan together. And when it comes to colorectal diseases in and of itself, I tell patients that, number one, if you're having an issue, rectal bleeding, change in bowel habits, things of that nature, okay? And those are the most common symptoms of colorectal cancer. They're very nondescript. All of us, I've had abdominal pain. I'm sure you've had abdominal pain at some point in your life, but we don't have cancer. You can have change in bowel habits. Sometimes if you're regular, if you poop like clockwork every day, and all of a sudden it's every 4 days, that's a change, okay? Or if you go every 3 days and now you're having diarrhea all the time, that's a change. So you know your body, you know these changes. If the change lasts longer than a month with you trying various over-the-counter remedies or Dr. Google, then you see your primary doctor. If your symptoms don't change after you see your primary doctor and you have a treatment plan, then you should before you leave that first appointment with your primary doctor, the last question should be, Doc, if this doesn't work, then what are we going to do? You always leave with that. So then you know. And if things aren't getting better seeing your PMD, then you need to see a specialist like me. And that's really the key. I think for so long, one of my subspecialties is young people with colon cancer. And what tends to happen with those are twofold. Sometimes they have these nondescript symptoms and they just, I'm young, it's probably hemorrhoids or this, that, and the other, but things don't get better and then they present late. Or unfortunately, sometimes they go to see their primary doctor, and sometimes even the primary doctor, it's probably hemorrhoids, so they give cream, but then patients don't follow up. And then as physicians, we assume everything's fine when it's not. And so those are the two biggest issues I try to tell patients is we're a team, and you have to know you have to be comfortable enough with your PMD to hear things you may not want to hear. One of the other big issues with African Americans is that the best test is a colonoscopy for multiple reasons, especially for African Americans, because I was mentioning earlier how all these tumors start as a little polyp. Well, for African Americans, most of our polyps are on the right side. Okay, you can only get there with a colonoscopy. What I tell people is colonoscopies, once again, are not done to find cancer. It's done to prevent cancer. So if you look at a lot of studies about why African Americans don't get screened as much as with colonoscopies or offered colonoscopies as much, it's twofold. Some of the data will say, well, there's a manhood issue with, I don't want anybody sticking anything in my butt. But even when you look at rich blacks versus rich whites, middle, poor, even rich African Americans will say that they're not offered a colonoscopy as much as counterparts are. So this comes into being comfortable with your patients and having your patients be comfortable with me. So 100% of the time, no matter what race somebody is that comes to see me, and I say it's time for a colonoscopy, every guy goes, "Oh, doc," or "Oh, do I have to?" And I'm like, "Yes, you have to." Now here's the problem. A lot of times with African American patients, if their doctor says, "I don't, you need a colonoscopy," and they're like, "I don't want that stuck in my butt," they'll say, "Okay, we'll just do this." And if I offer you a at-home kit that you can poop in and then study it versus me doing a colonoscopy, most people are going to choose this other test. These other tests, these Cologuard tests, these FIT tests are good at finding cancer, but it doesn't prevent cancer, and they're very poor at finding polyps. And once again, prevention is taking the polyp out. Okay, that's the biggest thing. And so when you're offered these inferior tests, they sound good because you don't have to have anybody stick anything in your butt. Okay, but the fact is they're not as good. And so I think I am comfortable enough with my patients where this is what you need, and guess what? They listen to me. Like, they listen to me because I've listened to them this whole time. I think the biggest mistake we make sometimes is you'll get a patient who's fresh and you're in this, dictatorial mode. And I don't believe that method works, especially not with, African Americans, Latino. Like, it takes time to build trust, because there's a lot of historical reasons why I shouldn't necessarily trust, certain studies, certain tests. We have a lot of reasons for that have actually happened. And so you have to build trust over time. And the key is that if you have that trust, a patient will do it because you explain to them why. And I think that's the biggest issue is that, once again, we have all of these constraints on insurance and health systems, and that's a me problem. That's not a patient problem. So I tell patients that they should always write down questions before you come into your doc. And to be honest with you, even if you don't have questions, if you just pull out paper and sit down here, it shows that studies show doctors will sit down with you. I always say that, we just lost a civil rights pioneer, John Lewis. And, you heard this whole thing about being getting into good trouble. What I tell patients all the time, and I share this personal story, is that for so long, our stereotype of being aggressive as a people is so not true. And especially in the medical world, Black patients will just listen to whatever the doctor says and say, okay. And doctors, we love that. We love good patients because we're in a hurry. But I tell patients that you being a good patient does not mean that it's good for you. So, John Lewis talked about good trouble. I talk about bad patient. What does that really mean to us? That just means well-informed. When I started at Cedars, I was a lot younger. I had less gray hair than I do now. And I noticed that I had a lot of young Caucasian patients, a lot of Jewish patients, and they would come in with articles and like questions and all these things. And at first I was so taken aback because that wasn't my cultural experience. I was like, well, do they not trust me? Are they testing me? Or is it because I'm young? Is it because I'm Black? And I realized it's cultural. I tell my Black patients when I started, I could say anything and they'll say, okay. And so I realized that is something that we need to work on, and we need to be more informative. And we always look at it as a sign of respect. Well, I respect the doctor. And it's not disrespectful to come and ask questions, at all. And that's been something I'm telling patients. I tell patients, especially African-American, Latino patients, look, you ask questions, that lets me know you're engaged, I'm engaged. We, once again, it's a partnership. And that's something that I really try to drive home, is that, yeah, we all, as doctors, we love patients. We used to walk in, walk out 5 minutes, but that does not do the patient a service. So that's something else that I think is very important. And I think all of this builds up trust. So then when you are talking to them about a colonoscopy, you get it done. The second biggest issue is they say that a lot of patients who are like refusing a colonoscopy, I always ask them, well, do you love your wife? Now, a lot of times they'll say, because women don't really refuse. I haven't had many women ever refuse, because I think women are used to it. I have two amazing daughters, 11 and 13. And I think I've come to realize you guys really are stronger than us. But the biggest thing is that women get invasive exams from such a young age. And for a guy, it starts at 40, right? So I asked them, do you love your wife? Now, about 50% of guys will say, yeah, but she'll be fine without me. I don't want a colonoscopy. Well, then I always say, well, do you love your kids? And they're like, well, what do my kids have to do with it? They'll be okay. I say, well, no, because if you get a colonoscopy and you have a certain number of polyps, for instance, or you have cancer, then your kids would get it earlier. So that would be an automatic, like you would get it 10 years earlier. And the point I used to drive this home, and this is a true story, which I've shared many times. My dad, who was part of a health system that will remain nameless, okay, was 50. And they basically just did a flexible sigmoidoscope, which I think is almost useless for cancer at this point. Flexible sigmoidoscope looks at the lower third of your colon and really the rectum, okay? Now, that test back in the day was great because any doctor could do it in any office, and you can actually help polyps, decrease colon cancer, because most polyps were on the left. Well, the reason that's never really helped African Americans is because our polyps are on the right, and now we see a shift even with Caucasians where polyps are going to the on the right side of the colon. We're trying to learn why. We don't know why yet, but the fact is that so then doing a sigmoid while you're awake is just going to torture you. So my dad has this done, and he comes in. I'll never forget it. I'm at home and he's walking like this. He's like, I can't believe you do this for a living. I'm like, what are you talking about? He goes, I just had that colonoscopy and I'm in pain and I was awake. I said, wait, you were awake? I said, Dad, did you drive yourself home? He said, yes. I said, Dad, that's a sigmoidoscopy. That's not a flex sig. He's like, so I had to convince him to finally get a colonoscopy about, maybe about 5 inches from where the end of that sigmoid scope. My dad had 5 polyps in his colon. And then on the right side, he had another 4. So I jokingly, anytime I wanted something or talk to my dad, I'm like, I saved your life, Dad. I made you get that colonoscopy, right? We took all those polyps out. So he was 50 when this happened. He subsequently has had about 15 polyps total. Okay, so I'm 45. When I was 42, because I knew my dad's history, because he had so many polyps, I got my colonoscopy early. I had a 2-centimeter high-grade dysplastic polyp on the right. And if I had waited till the national guidelines of 45, I would have had a cancer. So that's what people don't. So it is truly empowering. When you get a colonoscopy, you are saving your kid, potentially saving your kids and your grandkids' life. And it's really hard for anybody to say they do not care about that. And that's what I have to pull out the kids sometime in order to get people to get the colonoscopies. But it's true. It is true. If you know your family history and then you eat right, I mean, after that, and I practiced what I preached, but not as much until after that happened to me. I lost like 40 pounds. Like I've been trying to keep up because I thought I was doing pretty good, but I realized I have less wiggle room than maybe somebody else because of my history, things of that nature. And so it's really important. I mean, we talk about this stuff at the dinner table. My kids hear about colorectal polyps on a regular basis. They're like, Dad, I know I need to get mine at 39. That's what mine at 39. That's what I'd say to them all the time. And so it's important for us, not only when we get tests, no matter what test you get, you share it with your family. I make it a point of every colonoscopy or surgery I do, when a patient comes to see me post-op, they get a copy of their pathology and they get a copy of their op note. Most of them don't even want it. I'm like, nope, you keep it, because I want you to be able to talk to your family about this so that they know what they need. And I think that's how we really make a dent in this, is that the reason I went into this field is because So I lost my mom about a month before I graduated med school from breast cancer. She fought it metastatic twice for 10 years, 10 years. She was an amazing woman. I didn't go into that because I was too personal. My grandfather, who I didn't meet, or I met when I was maybe 2 years old, I don't remember. He died of colon cancer young. So I already knew I kind of had this going on, but my mom made it a point, and because my mom talked about her breast cancer experience, my sister had her BRCA tests, early. Like I said, my sister's gotten her colonoscopy now, and guess what? My sister's 43, and she had polyps also. So we know that. So now her son is going to know to get his early. So that's the empowering thing with this, is that you can fight this two ways. The whole diet is important, but it's important for parents because that's what you are able to teach your kids. That obesity is real. I mean, that number, it's interesting. When I was preparing for this particular interview, I was just updating my stats, but 70% of millennials are going to be obese, not overweight, obese by 35. That's a national, that's like COVID as far as I'm concerned, in terms of being an emergency, and and by the same token, this other hospital I have another office out in Orange County, and the hospital that's across the street there had a big In-N-Out burger truck yesterday in front of it. People lined up for burgers and fries. And look, everybody can do that once in a while, but I still think it's a horrible look when hospitals have that kind of stuff, because we do know it helps to cause cancer. It does. And I'm not a crazy person. Once in a while, sure, I'll have red meat. I have red meat like maybe once a month, once every 2 months. But what I tell patients is, if you eat red meat every single day, even if you drop it to twice a week, you can have an effect on your chances of getting all kinds of cancer. So every little bit helps. It's not a total sum game for young people, but I do start to think when you get to be my age, it starts to be a total sum game, meaning that I know that if I started eating red meat every day, all the time, I would have a cancer unless I'm getting colonoscopies every year. Right. So once you know that, knowledge is power. I don't look at it as, oh, dang, I can't do that. I look at it, well, hey, man, I know something that will hurt me. I don't have to do that. So I can live with my kids, my wife, and everybody else. I think that the key is for patients and physicians to know that they have a power in this disease. Even though it's the number 2 cause of cancer-related deaths, it does not have to be like that. The biggest data is that other countries where there is no McDonald's, there's no fast food, there's not colon cancer. Can you imagine that? Like there's no reason we should have it, because you don't have it other places. So, one of the other things that's non-modifiable when it comes to family history is your genetics. But knowing your genetics, even insurance companies will pay for you to get your tests earlier than what is recommended, because you have the genetic predisposition. So, I mean, that's my whole. I forgot what the question was, but that's how it's all in a nutshell.
Honestly, you answered every question that I had.
There you go.
But is there anything else that you wanted to note?
I just want to note that we can really, you can change if you have a genetic predisposition, but there's so many factors that we can change to make this not the number 2 cause of cancer-related deaths. In my opinion, it really should be like number 12. Okay. And the second thing is, the hardest thing it is for me to do is to tell my daughters no. Everybody loves these flaming hot Cheetos. You see the kids, like when I see that, I ask my kids, what's a Cheeto? Is it a potato? Is it a corn? Do you know? No, it is made in a lab. It is the number 1 processed food in the world. Bacon, all these things. You have to decrease the processed food. So my daughters, they know that they still get them. I don't know how, but that's the one thing. I'd rather buy them candy occasionally than fire hot Cheetos. Okay, for instance, because processed foods, these things really do matter. High fat, high red meat, low fiber diets are the worst. So I think that we really have to know that. But what I know is that you have to practice what you preach. Because if you just tell your kids that while you're eating fire hot Cheetos, they're not going to listen. And so I make it a game for the whole family. Like, we even started doing something that I never thought I would do, but one day a week, we're all vegetarian, And so, and I eat a little bit of, most of the other time I just eat fish and chicken. But I mean, like, even those little things. Even if you, like I said, you eat red meat 5 times a day, you want to go to 3 times a day, you're going to make a difference. So I don't want people to see all these stats, because there's a lot of myths out there that, well, if I get it, I'm going to die. No, the other good thing about colorectal cancer is if you catch it early, it's a 90% survival rate. Now, for African Americans, it's lower. The reason being is, number one, access to care and specialist access. That's the hardest part, is finding if you have different insurances like Medi-Cal or something like that, then it's harder to see a specialist, so the waiting times are long. But squeaky wheel. You got to be a squeaky wheel when it comes to that. And it takes both. Doctors can't do that for every single patient by themselves. Patients have to say, hey, how do I help do this too? And we work on it together. It's a team. And I think that's really the biggest thing, is that you're in it more than I'm in it, because it's your body. But if I'm in it 45%, you should be in it, 55, and we can do it. We can do it together. So that's pretty much it.
Great. Well, thank you so much for taking the time to speak with me. I really do appreciate it.